Hello and welcome to the Wiley podcast series, Knowledge to Impact, where medical education meets real-world change. This series aims to deliver latest content updates from our Knowledge Hub program. Today we present part 3 of episode 1 on Cancer Cachexia, featuring a panel discussion with Professors Aminah Jatoi, Jeffrey Crawford, and Dr. Rony Dev on proactive detection and management strategies. This discussion was originally broadcast as a webinar. A link to the original accredited activity, including information on how to claim credit, faculty disclosures, and the slide presentation can be found in the show notes. We're glad to have you with us, and we hope you enjoy this episode.
Hi, this is Dr. Dev here with the supportive care team from MD Anderson, live with our panel of Cachexia experts, Dr. Crawford on video and Dr. Jatoi on phone. I was going to start the questioning with the first question to Dr. Jatoi concerning healthy weight loss versus distinguishing that from weight loss due to a serious illness such as cachexia. Unfortunately, America is undergoing an obesity epidemic. Patients who are on weight loss medications, and sometimes they don't realize that weight loss can be not necessarily healthy.
Thank you, Dr. Dev. That was, I just want to also say your case presentation was really wonderful. So thank you for that. And also want to just compliment Dr. Crawford for a very nice presentation too. This issue of weight loss and trying to distinguish between weight loss that is good and weight loss that isn't good. I think it's important to realize that the weight loss associated with advanced cancer is very different physiologically from the weight loss that occurs when we feel like we've been maybe eating a little bit too much and are trying to lose weight just to stay healthy. If one looks at those types of weight losses, those types of weight loss that are happening in different people, somebody with illness versus somebody who has a disease such as cancer, physiologically, they're very different. If one just tries to lose weight and is otherwise healthy, one will lose mostly fat. And that's been shown clinically with body composition assessment. In contrast, if one is involuntarily losing weight and has a serious disease such as cancer, the body composition changes are very different. Lean tissue wastes at a much more progressive rate than fat tissue. And I think that has made many people say that lean tissue is a critical component of health because in the setting of cancer, it's wasted predominantly. And it is what really impairs people's ability to get around and do what they want to do. It compromises performance status. So they're two very different processes. I'm not here to really talk about the benefits of weight loss in healthy people. You alluded to that. But certainly in the setting of disease, serious disease such as cancer, it's a very different process. Oftentimes involuntary too.
Thank you. I have a question for Dr. Crawford, mentioning cachexia being the tip of the iceberg. What is the best way to detect cachexia early, and what kind of tools can be used in the clinical setting?
Well, thanks, Dr. Dev and Dr. Jatoi. It's good to join you both. It was good to see us all approaching this very serious problem with a little different angle, but some common themes today. So that was helpful. I think that the way to approach the diagnosis is really by measuring weights and by knowing what past weights were. So monitoring weight over time is the most helpful way to kind of assess the presence of cachexia. And asking the patient. So if you're seeing the patient for the first time, asking the patient and their caregiver whether weight loss has been part of the program or not, that's important. I think one of the issues that you alluded to is that in our society, we're now looking at weight loss as a good thing in the healthy person. And so sometimes the patients that have cancer think that weight loss is not an issue and not a problem. But clearly, as we've all pointed out, it is. But I think the best way to follow this is with serial weights. And I think For those of us who have electronic health records, it's relatively easy to do. You can even modify the EHR so that you can look at the degree of weight loss over time, or hopefully weight gain in some of our patients.
Thank you. Another question for Dr. Jatoi. Cachexia often causes distress in not just the patient, but caregivers. And often this results in requests for unusual supplements and diets, and also TPN. How can you counsel patients effectively and address their distress?
Yeah, I think that's a very serious set of issues that you've alluded to, and that the person who prompted the question, who put the question in the chat, has really targeted something that takes a lot of effort on the part of healthcare providers. And there's a lot of guilt. There's a lot of frustration that everybody feels when a patient is losing weight and continues to lose weight in the setting of cancer. And as I think has been described during really all of our presentations, patients change. They're less functional. They're not able to do as much as they used to do. They don't eat as well. Their appetite is gone. And also because they're predominantly losing lean tissue, they're not as functional. And that's very challenging for family members to see. I think providing emotional support to everybody, and acknowledging that cancer isn't just a disease of a person, but it affects everybody in a family, and everybody in a patient social network. I think we have to recognize that, acknowledge that, tell patients that, tell people who are at the appointments that, and at least acknowledge to some extent what they're going through to the best of our abilities. I think there can be some strife related to trying to push food, because an underlying aspect of this whole syndrome is the loss of appetite, and the patients just don't feel like eating. And if, we as healthcare providers or family members try to push it, it just becomes more and more of a struggle, and it can be difficult, and at the very end of life result in a lot of guilt. I don't know that there are many other options that come into play. We do have drugs that can help patients with cancer, rev up their appetite, and they've been talked about. Olanzapine potentially, megestrol acetate potentially, low doses of dexamethasone potentially. They help some people, and sometimes that means a lot, but they don't deal with the overlying syndrome in its entirety. They don't improve survival. They don't help with functionality, but they play a very important palliative role, which some patients might want to make use of.
Yeah, I agree. It's a challenging conversation at times, and healthcare providers do need some training in those types of discussions. Next question for Dr. Crawford is regarding dietitians, how to get them involved, as well as other team members. Again, cancer therapy often involves a team to treat the cancer, as well as management of issues such as cachexia.
I think the involvement of the dietitian early on is really critical for all patients losing weight. I think they can benefit from someone reviewing in detail what they're eating now, and answer their questions about what might be more appropriate dietary supplements for them to try to maintain their weight. Obviously, most of us talk about high calorie, high protein foods, but they can get a more balanced discussion with the dietitian. And you're right, this is almost all supportive care depends on the whole healthcare team, not just one member. So it's not all a dietitian. It's got to be partly by us as physicians, advanced practice providers, nurses, chemotherapy nurses, all sort of talking about these issues and helping diffuse some of the issues that Dr. Jatoi was talking about, where it becomes confrontational between the patient and family about, oh, why can't you eat more? Why can't you eat my food? So that only adds stress. It's also context dependent, right? So very early on, the team approach, the real encouragement to try to reverse things is an important part of the management of the overall care of the patient. At end of life, it's a different discussion about how important nutrition is, but that's often when the family member is really saying, that's all I got left is food. And so letting them know that it's not as important at that point. It's not going to make a difference with food at the end of life. You might at the beginning of the disease course. So the context is very important about how much we emphasize different aspects.
Absolutely. A question from the audience for Dr. Jatoi, how to distinguish between malnutrition as opposed to cachexia?
Thank you, Ronnie. I think that's an extremely important question. And there are many definitions of Cancer Cachexia that say that this is a syndrome that is refractory to caloric repletion. You can try to feed patients. You can try to push parenteral nutrition. You can try to push enteral nutrition. You can do all kinds of things. And in fact, what oftentimes happens is those efforts backfire in cachexia. And I find it, as an oncologist, I find the distinction sometimes hard for non-oncologists. But I think there's a very important, it's a very important point, and that is if a person has an early stage cancer, and if they're losing weight, it could be malnutrition. In contrast, if it's a late stage cancer, it is really the stage of the cancer and the likelihood as to whether the cancer can be treated, which I believe determines whether we're dealing with cachexia or malnutrition. With a late stage cancer, with an advanced cancer, with an incurable cancer, if patients look like they're malnourished, it probably is cachexia, meaning giving these patients nutritional support will not help them. It can help a little bit, and it's a good thing to encourage patients gently to eat, but that's where there is this effort on the part of many throughout the world to find drugs, pharmacological interventions that will help with cachexia. And I think that's a very important point because, we who see cancer patients and who treat cancer have to, I think, take the lead in terms of this definition. Is it malnutrition or is it cachexia? Because the discriminating factor is really resting upon the cancer and whether treatment is curative or not, or treatment is associated with a very high likelihood of success of therapy, even short-term success. And I don't know if others, like Lonnie, you're doing a great job as moderator, but I'd be curious if any other members of the panel, either you or Jeff, have a different take on that. As Jeff said earlier, we all kind of came to this symposium with maybe different philosophies and different approaches. And I'm continuing to learn definitely from both of you.
Yeah, I don't know if Dr. Crawford has anything to add.
I agree, Aminah, with what you said. I think that the distinction is, cachexia has an important impact on outcomes growth, all talked about early on survival, but late, the palliative nature of it. And I think it really mimics what we do in cancer management in general. So I think what we do early in management is different than what we do late. So it has to be in the context of the patient and the family. But I think the basic principles around nutrition and exercise and specified pharmacologic intervention specific to that patient, I think that applies across the whole continuum.
Another question for Dr. Crawford from the audience. The contribution of systemic inflammation to muscle wasting, and also tied in with a question about tailored, enriched non-clinical food or specific nutritional interventions that could mediate or treat some of the underlying mechanisms of cachexia.
But both good questions. So I think that is certainly one of the distinctions between malnutrition and cachexia. That is systemic inflammation that occurs as part of the cancer or other chronic inflammatory condition. And we know that these cytokines, when they're higher, do have negative effects. They have catabolic effects on muscle, causing maybe a greater degree of muscle loss than we would see otherwise. And that's, I think, why early on, before we understood some of the CNS drivers of cachexia that a lot of studies focused on. We were trying to reversing IL-6 or other cytokines to see if that would reverse the syndrome. Unfortunately, it didn't do that successfully. So I think while inflammation is part of the overall milieu of having cancer and cachexia, it doesn't seem to be central by itself to outcome. Whether in conjunction with other cachexia agents it might be, I think we'll have to wait and see. In terms of non-clinical foods, I do not have a lot of experience with that. Certainly, I think we do understand right now what we have is nutrition, and nutrition is important. We have shown, the MENAC trials nicely shown that if you can emphasize nutrition, you may be able to at least stabilize weight loss, if not reverse it. So I do think looking at both non-clinical foods and other supplements are an important area of research for us.
One last question from the audience to Dr. Jatoi. Do antidepressants help with cancer cachexia?
Yeah, I think that's a great question too. If there is a component, I think, of depression that many patients with cancer experience. I mean, we all know that. And as oncologists, we probably underprescribe antidepressants. I think there's some literature to suggest that. And certainly part of depression is poor appetite and just feeling despondent. So I think antidepressants can help. There have been some trials with some antidepressants, and I think the results have been somewhat mixed. So what I would say is that it needs to be individualized for the specific patient, whether to prescribe an antidepressant for somebody who's depressed and losing weight and also has advanced cancer. I think it sounds like a very reasonable approach. Similarly, and maybe going a little bit off topic, but treating other symptoms, there are times when patients are struggling with, some other sets of issues such as pain. And I've seen many instances where if you treat the pain, patients start feeling better, they start eating better, their well-being improves. So are you treating the pain or are you treating the cachexia? Patients are so complicated, sometimes we don't know, but I think sitting down with patients and trying to figure out what the predominant set of issues seems to be and then proceeding from there makes sense. So I appreciate that question very much.
Yeah, I agree. It's a complex phenomenon, and to kind of summarize, I think there's a stress on early identification, and also the subjective symptom management, things like anorexia, nausea, anxiety, depression, and you have the treatment of the patient-centered or personhood, and the subjective symptoms to improve quality of life. Also issues like body image distress and other distress for caregivers as well. And then there's also the objective signs and symptoms, the loss of muscle mass, decrease in functional status. And these issues are just as important, issues of body composition, changes in muscle mass, and identifying that in patients who are obese is also critical. I think the future direction is also involving biomarker therapy, treating the pathophysiology, things like underlying chronic inflammation, also increased sympathetic activity with beta blockers, also hormonal changes, ghrelin resistance. The ghrelin agonist may be beneficial in certain situations. And then the more recent targeted treatments, targeting TDF15. In the past, we didn't have great therapy for cancer cachexia. Hopefully, in the future, we'll have more disease-specific therapy without forgetting to also treat the patient and the person. Again, thank everyone for joining, and I appreciate everyone's questions. Thank you.
Thank you for joining. If you enjoyed today's episode, don't forget to share it with your colleagues and subscribe to our channel. If you'd like to learn more about cancer cachexia, you can access additional educational resources, including CME credit opportunities, on the Wiley Knowledge Hub. For more medical education from Wiley, visit Wiley Focus. All links are in the show notes.